I'm Josh McDonald.
And I'm Tristany Berry, and we are Hand Therapy Academy.
All right, Tristan comes to us with another question. Tristan, what do you have for us today?
We recently had a patient that kind of sparked some concern for me, so I wanted to ask you when does a wound kind of turn our head a little bit and become concerning?
Yeah, you put that very delicately. I think maybe the better question is when should you be scared to death because that wound looks super, super sketchy? Yeah. So we see all kinds of wounds that come in, right? And patients come in with like the distal radius fracture scar line, and they're like, oh my gosh, it's so gross and disgusting. And you're like, that's nothing. That's not that big a deal. We forget that patients aren't used to seeing what we see. And then you have patients come in and like, okay, I have a plan in mind. We're going to do some xeroform, we're going to do some adaptic, and we'll progress on. Then there's the patient that comes in and you're like, oh my gosh, that is half a centimeter deep. There are structures I can see that I shouldn't be able to see. There's things inside there, and they're like, oh, I don't know, it's squirting and it's kind of going everywhere. So, yeah, I think there's like different levels of DEF CON awareness that we go through. And so I don't really have like a category to say like, okay, this one I don't care about so much. This one is easy. And but I would say when I feel like it is past the layer of the base of the dermis, and that's hard to identify. But when I can honestly, from a basic perspective, when I feel like I can see other stuff, right? Like there's like, okay, I see other things inside there. We put a post up a while ago. Maybe this was a year ago. A patient texted me on a weekend. He texted our line, and I just happened to get the alert. I'm working in the garage, and he's kind of a nervous Nelly. And he says, I think I see a tendon in here. I'm thinking, no, you don't see a tendon. It's fine. And I watched the video, and he's closing and opening his hand, and he closes. And then, oh my gosh, there's white structure, a white, like 3 millimeter long, 2 millimeter wide, pops out clear as day. I'm like, oh my gosh, that's your flexor tendon. So I called him and we went a different direction. If I feel like that wound has a depth that is, depending on the structure, but like 3 millimeters or more, and that's hard to visualize. So I'll maybe even pull out my little ruler and visualize 3 millimeters. I'm not putting it in their wound, but I'm getting a visual on like, okay, this is a deeper wound, or it's wider than it should be. If it's the zigzag stitch, and you see something in this patient's case where like, okay, that is now dehisced or opened. It was closed. We know the doctor didn't send them out of here, out of the OR looking like that. That is opened back up again, or it's gone backwards in status. Maybe the coloration, we talk about colors of wound, it's yellow. There's a significant amount of exudate or drainage coming out of it, and that is white or yellow. That raises my concern quite a bit more.
And what are the signs of infection? Because that's kind of our biggest concern when a wound opens.
Yeah. And so we talk about a color system, and the big color we're all looking for is yellow, right? Like if it's yellow, well, I'm not great with colors. My wife has some design skill, and she'll say, "Oh, that's got yellow in it." Well, that's not yellow, right? Like I'm expecting like yellow, right? Like banana yellow, canary yellow. I want something that's distinct. It may have like a grayishness to it that's like just not normal wound. We've all fallen or had kids scrape their knee, or and like, oh, well, that's just like it's not skin or red. There's something in between, and the whole wound may not be yellow. You may have areas of the wound where you think like that distal aspect looks a little concerning. So I'm looking for color. I'm looking for a different kind of exudate that's thicker, noticeably yellow, noticeably white, like a pus kind of drainage. Or if there's something that is, if there's streaking, if there's like coloration that works proximal up the upper extremity from the wound, and you see that streaking, redness and white streaking contrasting as they go up. If you see streaking, you're either sending them to the hospital or calling 911, because that by definition means that is going septic and it's going to the bloodstream and is about to go everywhere. So if you see streaking, that is like DEF CON 1. That is our most important level of concern. That's a big deal. But otherwise, I'm looking and saying like, okay, is there structural integrity on that tendon? That patient with the tendon that popped out, he wasn't yellow. He didn't have drainage. He had really poor circulation and healing as a young guy. And so we didn't see yellow, but I'm like, there's a structural compromise here. Or If we keep doing range of motion, I can tell this is going to keep opening. So we have to change our plan of care so I don't make it worse and instead can take it the right direction.
Yeah, and can we talk about products to use too? It's for me as a new therapist, it's really overwhelming. There's so much going on. So, what is kind of your standard with a wound that just kind of popped open and we're concerned?
Yeah. So let's assume that there's no major infection. Let's assume it's just like open, right? Like, okay, it's either dehisced and reopened or it was never really closed all the way. We rely on Xeroform, Adaptic, and Telfa. That's almost exclusively what we use. Most of our patients that need more than that have wound care nurses following them. And so that doesn't usually become our concern. They don't put that on us as therapists. Some clinic have to deal with that, and so that's a different issue. I'm going to rely on Xeroform, possibly like a bacitracin if it's very deep. If it's the purpose of Xeroform is to act as a secondary synthetic skin to protect it from drying out and intrusion of outside bacteria, and to keep dressings from sticking to any exudate drainage. So I'll use that to keep that wound bed that has some depth to it um, moist and humid sufficiently without using a big piece that covers the skin around it to macerate and weaken the neighboring superficial epithelial cells. I'll use, if it's too deep, if it's like 3 millimeters or deeper, I'll take a sterile tongue depressor or toothpick and I'll put a little bacitracin on it, maybe triple antibiotic, not neosporin, and put like a pea-sized blob on there, and I'll spackle that into the wound. And I say spackle because I want that bacitracin flush with the surface epithelial cells and filling that void. And then I'll put a little bit of Xeroform over top of that to keep the bacitracin from absorbing into gauze or whatever I'm putting on. And that keeps it moist. And those epithelial cells around the border of the wound need to migrate over. And if there's a step off down into that granular wound bed, those epithelial cells will catch at that cliff theoretically and not be able to migrate over and close the perimeter of that wound. That bacitracin helps those epithelial cells migrate into that space. All that to say, if they still have exudate, I would throw Telfa on top of that so they're not oozing everywhere, making family members gross.
Yeah, and can we touch a little bit more on the size of the Xeroform you're using? I've learned from you that the piece we need is so small, and I think that I would have never known that before. I think it's important to know.
Yeah, yeah. A lot of times when they leave the doctor's clinic follow-up visit, it's an MA that's dressing them. Or if they're leaving the surgery site, it's just a post-op nurse who's dressing them, and they have orders for Xeroform. They'll open a pack, slap it on, wrap it up, and send them out the door. That Xeroform, because it increases the humidity and the moisture of the area, will add maceration to any area that is at the right level of humidity. It increases it everywhere. So we have lots of patients who come in with these big old patches on a little 1 centimeter circumference wound, and everything around is macerated and weakening, and stitches are pulling out. And so I'll take the size of the wound and cut the Xeroform to match that. Sometimes I don't have to trim it exactly. I'll just kind of scoosh the edges of the rectangle in so it's not overlaying healthy, moist epithelial cells. But yeah, very, very small is all that's needed. I may use like if I take my 1x8 and stretch it out, I may double it over once and add that in there. If it's a big space, like a big forearm wound that's open and drying out, I may take 2 or 3 layers because there's more bulk to absorb moisture. But I'll see patients come in with like 5, 6, 8 layers, and that's just adding too much humidity to the area.
Sure.
We did have a patient come in that's interesting to touch on that was not wound based, but he had had a digit widget that failed because the pins wouldn't stay stable in his P2 bone. And so he came in just kind of off the street for us and said, after the digit widget had been removed, deciding what to do, he comes in and says, I can't sleep. I'm in so much pain. And he puts his hands up there for us to see. And his affected side with this PIP flexion contracture, no more digit widget, that was taken out. And he's probably a week and a half removed from that coming out. and his hand is 50% the size of the other one. So inflammation, he has temperature difference, it's warmer to the touch. He had coloration change, and he had loss of motion. He did not have streaking, but everything about this wound screamed he's got an infection. He had been to, his provider was out of town, his surgeon was out of town, so he went to a different provider, different hand surgeon across town, and he gave him oral antibiotics. He had not been able to get those within 36 hours, so he comes to me saying, what do I do? We were able to figure out with his provider who was out of town, talked to her on the phone, start oral antibiotics, but if that doesn't make a difference, then we're going to send him to the ER for blood work because she's out of town and can't do blood work till Monday. So sometimes it's not a wound issue that's an external infection obvious, but we can see signs subdural. We can see signs in a neighboring area or the whole hand to say like redness, temperature, color, pain, loss of range of motion, maybe streaking. All those things are major signs that we need to like escalate our level of awareness. Yeah. So hopefully some of those things are helpful for you when you get wounds that are a little scary. If there's infection, definitely go back and talk to the doctor about that. If you have concern about that, it's always better to talk to the doctor and him or her say not that big a deal than to have missed that opportunity. So always go back and ask the surgeon if you're not sure. But then there's some ways to manage those wounds that maybe aren't infected, but we need to keep that granular tissue populating well. Yeah. If you have any questions or need to reach out to us, do so with our email, info@handtherapyacademy.com, or via our social media accounts at Hand Therapy Academy.